Hi, everyone. I'm Kat Vlasica. I'm the Fellowship Director of Acute Pain Management at St. Joseph's Health. We're going to talk about a topic that is, I am sure, at the forefront of everybody's mind. It's billing and coding. So we go into medicine because we like to take care of people and do all the noble things that bring you into medicine in the first time, but nobody actually tells you how you get paid. So I'm going to talk a little bit about coding as it pertains to regional anesthesia with that heavy focus, because this is a topic way over 30 minutes. We also have one of my really good friends that we're lucky to have. Her name is Dr. Beth Kushner. She's the CMI of our hospital, and she's also a professional coder. So she's going to be an amazing resource for this. So just to start off with, why do you care? It's basically we all emerge out of residencies not knowing anything about billing or coding or about the rules of the game. So we need to know the rules of the game that are played by the people who generate your paycheck. The reality of medicine, it's pretty stark in that it's RVU based, and that's what your paycheck is paid for. And this is what pays for building of programs, the attaining of equipment, and your protected time. So you can actually spend more time in academia doing the things that you love. But you need to know the rules of the game. So, just as a basic framework, you have two buckets of reimbursement that are involved in getting paid. And this is specific to hospital based reimbursement. You have the facility fee, and those are the things that the hospital gets paid for having a patient simply walking in through the door. That's your triage, your registration, your IT services, the people who are working in environmental, the basic salaries of maintaining a brick and mortar shop. And then you have the professional fees associated with the payment. So those are the fees that are generated by the physician. So that is your medical exam, your consultations, your surgeries, and the procedures that you do to the patient. For the sakes of what is going on, we are going to basically briefly mention that facility fees are usually when you work in a hospital-based shop. The most of the reimbursement is going to be for the facility fee. However, we are going to focus on the professional fees that we generate here as physicians. Two main players that determine your professional fees, those are your ICD-10 codes. These are the codes that are defined by the World Health Organization, and this is a standardized approach to medical diseases and injuries. And then you also have your CPT codes, or your current procedural terminology coding system. The CPT codes determine the number of RVUs that you generate when you see the patient, and this is typically a 5-digit code. Now, CPT codes, or your interaction with the patient and the things that you do, generate an assigned RVU, and there are three components of this RVU that are taken into factor. So you have the work of the physician. So that is the time and the effort that you spend taking care of this patient, the skill level and the judgment and the stress level that are involved in taking care of somebody. Then you have the practice expense. So that is the expense of running a business. So salaries and benefits and the rent of your medical practice and the equipment and your supplies. And then you have the cost of malpractice, which is pretty self-explanatory. Now, the cost of running business or being a physician is different in different parts of the country. So you have something called the geographic practice cost indices. So that accounts for the geographic differences for the cost of practice across the United States. So all three components of the RVU get multiplied by the GCPI, and then you have a value added to that. All of these values get added up, and that's what forms your RVU. And that's how the RVU gets generated. Now, the RVU has to be multiplied by something called a conversion factor. And that takes that RVU and converts it into an actual dollar amount. This dollar multiplied is updated by a formula specified by statute, and it changes on a yearly basis. For 2024 for Medicaid, it's $32. It's down from $36 from 2020. You multiply your RVU by your conversion factor, and that determines the amount of money that you generate. The RVUs are actually, which was mind-boggling to me, and I had no idea about this, is that the RVUs are different in all different parts of the country. So if you work in the Northeast in a higher expense area, you're going to get paid a little bit more per RVU than if you're in one of them square states in the middle. Anyhow, the conversion factor varies greatly. Medicaid and Medicare typically pays a lot less than a private insurance. However, that does not automatically equate to what you're going to get paid, because some payers have these alternate methods of payment, and it's different for every single payment, just to make things a little bit more complicated. And some some insurance carriers actually will say, okay, well, that your RVs and claims are really cute, but we're only going to pay you a percentage of what you guys are claiming. So that's the contract that your hospital has with individual payers. So it gets really murky and really complicated, and there is no way of predicting what you're actually going to get generated. The best advice I can tell you that you can garner the most amount of reimbursement is that you focus on your documentation. So you can actually make your procedure note as buttoned up as possible so you can claim all of the billing elements of your procedure. So when you start doing these things, such as regional anesthesia, you ask your anesthesia colleagues for guidance. And typically what happens is that you get handed one of these little cheat sheets that they give you with little check marks on them. And it's kind of a good start, but our workflow is a little bit different than what the recovery room or the post-op recovery room does. So you have to actually kind of make your own procedure note and make sure that you hit the certain elements of the procedure notes in general. So here are the elements that you have. You have the medical legal aspects, which we all know and love. And when you start writing procedure notes, you have to actually make sure that you're covering yourself from a medical legal aspects. However, the little bit of an unusual component is the billing metrics and the billing aspect of your procedure note itself. So a couple of the things that I'm going to just point out, I'm not going to go through every single one of them, is the actual indication for the procedure. Now, if you have somebody with a fractured hip, nobody's going to question the indication for the block, right? You have somebody who is in pain, they're 90 years old, they can't take many medications, they're going to vomit blood at you if you even look at them, if they even look at a bottle of Advil, yes, you're going to block that patient. That's pretty straightforward. However, you have somebody like this that we had, for example. Now, this was a patient that we had. We ended up doing a tap lock on her for uncontrolled pain from zoster. You have to actually make sure that the indication is clear in your documentation for this block. You cannot just do the block for funsies and just document it as such. You have to, in this patient, when she came in, she was already on a really good regimen by her PMD. She was on steroids, she was on gabapentin, she was on topical medications, she was on Tylenol and NSAIDs and still could not sleep at night. You just document pain unrelieved by X, Y, and Z, pain unrelieved by parenteral medications or these interventions. This was the next step, and that's why we ended up doing the block. Another common caveat, I'm
Can I
sorry?
just can I just also add something? And when you're going through indications, it's
Mhm.
very, very common in today's day and age that the insurance companies are going to run your note through some type of AI algorithm. So you're going to want to use important terms like the term intractable pain. When they run that through their algorithm, it's going to shoot out a yes, we'll pay the claim versus a denial. And the name of the game is to decrease the amount of denial so you have a clean claim, so you get your revenue realized a little bit quicker without anyone else having to do an intervention and taking a percentage of that money. So intractable pain will be a lot better and it's a lot quicker by just using that word intractable.
Hey, Beth, can I ask a question on this? Is Arun. I'm sorry. It's a really, really important point. Now, I want to ask one really, I think, relevant question to me. Is that
Mm-hmm.
whenever I've designed worksheets for our department, and there's always this pushback, not from a lot of people, but people want to have their own indication. Well, I do it for this reason.
Mhm.
And they want to have a blank feel on the indication, which I feel is dangerous because if they again put toe pain and do an echo, we're
Yep.
gonna lose claims. So how do I balance one, making sure that I'm not too rigid in the sense I'm only forcing people to do it. Like if I'm doing a femoral nerve block, I do hip fracture, this fracture, that fracture, intractable pain. How do I
Yep.
prevent this from happening?
So it depends on your EMR. We are a Cerner shop and I work with CAT. So I'll just talk about our shop and some of the things I do here and then when I consult. I always give the doctors top 5 most common indication, or depending on whatever it is we're shooting for, a top 10 list. From there, I also give an other, which is like a free text field. So I can give that special somebody their special moment to have whatever it is that they're going to put in. But 90% of your doctors will choose your top 5, top 10 pick list. And that's something that we've curated to help us get the claim out.
All right. I think you broke
Random
off, Arun, so
stuff. If you leave the open and then people are putting in more and more random stuff, your collection rate will go down dramatically.
Yep. So the way that you end up collecting money is you put, so let's say you bill something, so you drop a bill, it goes on a claim form. Your claim goes out through a clearinghouse, it gets scrubbed, it then goes to the insurance company. If you get a denial, typically a billing company will go in and work your denial. And the way that they get paid is a percentage on what they collect. So instead of your group collecting, let's say $100 for that block, they're going to take 8% of that. So instead of getting the full 100, you're now going to get $92. It For you as an individual, as a provider, you're not going to really see the hit in the RVU. But if you're trying to make a new service line profitable or showing how you're going to do this so you get a new ultrasound machine or whatever that trade-off is, they're gonna look and say, well, your denial rate is, you know, 14%, and so it's not financially viable. Did that make sense?
Yeah. So give them a little bit of freedom, but really push them to using the indications that are already limited.
Yep, there's techniques and ways to get what you need done, understanding what the insurance companies are. It's a game, and we're here to play the game within the bounds and the rules to become winners. And so you just kind of have to massage some of the things.
What we've done is usually I have drop down menus of indications. So they can just click and pick one, and that just screams to our inner click happiness. So you just give them a couple of options that are reasonable, that are typically not denied. And that's usually a good way of building your procedure note. Another thing I just kind of wanted to touch on is the indication for the procedure note. Just be careful of putting that indication for the procedure, for the block as another procedure. So for example, in this patient, if you put in the indication for the block being a shoulder reduction, that might get denied because that might get bundled into the shoulder reduction procedure itself. So you have to put down something like intractable pain, which is actually a perfect option. So just be careful of bundling indications for other procedures. All right. So it cannot be a part of another procedure. Imaging guidance in itself. So a lot of the procedures, we're all doing these guided by ultrasound. Some people do it by fluoro, but just keep in mind that some of the CPT codes now include imaging guidance. So just keep these things in mind when you're looking at your reimbursement patterns. Typically, all of the brachial plexus blocks with the new 2023 updates, now they're folding in the imaging guidance building into the CPT for the procedure notes. So I have a list of all of those at the end of the talk itself. For the purposes of collecting data and in terms of an audit, what you're really required is to have an image that is stored that is actually findable in the patient's chart. So you do have to store an image, not just for medical legal purposes, but also for billing purposes itself. And you have to document that in your procedure note. So that's when you build your procedure note, just put down images stored. And hopefully that is your workflow. And then in terms of the other components of the procedure note itself, keep in mind that a lot of the coding, as Beth was mentioning, a lot of this is done by AI right now. So you have to make all of these data points very easy for them to find in the procedure notes. So imaging guidance, yes, we store the image in the procedure notes. Also, another thing for billing is the medications that were given to the patients, because you do actually want to get paid for the meds that you give to the patient. The trainee supervision, just make sure that there is a built-in attestation note at the end of the procedure note. And also put down which nerves you have anesthetized in that procedure. Now, I cannot tell you how many times I'm co-signing a note for serratus anterior block, and the resident will write down something like medication injected into the serratus anterior plane, but it does not tell me which nerves were anesthetized. This is going to come into play later on in the talk when we're talking about procedures that do not have their own CPT code. You have to actually show which nerves were anesthetized in this fascial plane block, if that makes sense for right now. The other components of the note that we do throw in there, and at the end of the talk, I have a QR code linking to our procedure note. I'm not saying that that's the end all be all, but when we built this note, I worked with Beth and our coding team on this procedure note, and we really don't get that many denials outright based on our documentation. So I'm just going to have a link to the procedure note itself. You have to have the name of the procedure in there. Do not assume that your coders know which procedure you are doing. The laterality, what is left, right, bilateral, because that has different CPT codes. For medical legal reasons, obviously, you're going to put in a neurovascular exam and consent. sterile or aseptic prep, needle size and type. And at one point they asked us for needle approaches, so we just put that in there. Whether there were any complications. We always put down limb alerts on our extremity blocks itself, because when our elderly patients go upstairs, some certain things have happened, and the time of the block completion, and that helps our anesthesia colleagues whenever they're trying to decide whether the patient needs to be reblocked or not. And just at the end, because we don't have much time, I'm just going to go through some of the common CPT codes. So for the headache blocks, you actually have a subset of CPT codes ranging anywhere from 0.7 to 1.36 RVUs. In the upper extremity, you have the brachial plexus, which carries the most of the upper extremity, which is 1.5 RVUs. And then when you get down below the axillary nerve, you're essentially coding these as peripheral nerve or branch, which carries 0.7 RVUs. For the brachial plexus and axillary nerve, the ultrasound guide is now folded into the procedure itself. For the truncal blocks, the tap blocks or rectus sheath or subcostal tap blocks, that is the only fascial plane block with its own CPT code that we commonly deal with. And it's separate whether it's unilateral or bilateral. And then you have the paravertebral block, which is the only large scale volume block that you have for the intercostal nerves. And that's going to come into play later on, but that carries 1.7 RVUs. And then in the lower extremity, in terms of the three different blocks that you can use for the hip, the femoral nerve is the only one with its own CPT code, which is 64447. That actually can get interpreted as a fascia iliaca block, depending on how your coders approach the billing aspects of this. And there are a couple of modifiers that you should be aware of, whether it's a bilateral procedure or whether this is a difficult procedure. Basically, anytime you use a curvilinear probe for a tap block, you should consider putting in a 22 modifier, but you have to document this very well. Had to use a curvilinear probe due to patient's significantly elevated BMI. Landmark is at this depth. So that has to enter the procedure, because that increases your billing by about 20 to 25%. Now, the one thing I do want to talk about is the fascial planes, because we've had a lot of new blocks out there and none of them have their own individual CPT code. So now one of the updates has come up that these blocks cannot be billed as a peripheral nerve block that is blocked within that fascial plane. So I'm actually quite impressed that the AMA has figured this out. They have basically declared that you cannot bill a fascial plane block as a peripheral nerve block. So for a lot of the blocks that we do in our department, this is kind of an issue, because a lot of them do get billed at 64999, which does not carry an RVU value, but that does not mean that you're not getting reimbursement on this. Now, for fascia iliaca, I've actually kind of come back to our coders and I had them look at all of our suprainguinal fascial iliaca blocks that we do in the department. And they've just simply continued coding it as if it is a femoral nerve block, because that is the only close CPT code that can give you the value of that work. The problem arises in the erector spinae and the serratus blocks, which are essentially intercostal nerve blocks in a large volume in a large fascial plane. And the only thing that is actually similar to that block would be a paravertebral block, which carries 1.75 RVUs. However, a lot of our coders are not able, from what I've seen over the past 6 months, our coders have not been able to bill it as a paravertebral block. They have been billing it as a single intercostal block. So this is sort of where our payment has not really been great with this procedure itself, because we have not been able to get that reimbursement. So the moral of the story is track your billing and track your reimbursement on this, because it's pretty illuminating and you see where the work needs to happen in order to optimize your payments. PANG also is another one of those blocks that does not have its own CPT code as well. And typically what we're able to get out of that is the simple peripheral other nerve block, which is 64450, which carries only 0.75 RVUs. And we all know that that's not the worth of that work. The other thing I was going to bring up is that brachial plexus, sciatic, femoral, and paravertebral, all of these procedures now have the ultrasound guidance built into the CPT code itself, so you cannot bill separately for that. And if you're doing joint injections, that's pretty straightforward. It's 20611. We do a lot of them, so we actually do throw that in there. And that's pretty much it. That's all I have for you guys. The QR code that I have up here is a link to our Dropbox with a list of the common CPT codes, their RV values, our a procedure note, and the references for this talk. And that's a picture of our 12-year-old jumping off of a cliff because we're parents of the year.
That was incredible.
That was amazing,
Wow.
Kat. Thank you.
Thank you.
I was really, and I have a ton of questions. I'm going to let somebody else start. Nobody wants to go. I'm happy to ask some questions.
Oh, please.
So one, to simplify this for us, and this is something we're switching to now. So this is a very apropos and good timing for me, is we've kept it very simple for all of our blocks. It's just needle guided procedure, and just to get it going. Mm-hmm. And so we've done for 10 years. We have pretty good data on what we're doing for our blocks, and we've just made the simple ultrasound guided needle procedure. I can't remember the exact CPT code. Beth probably knows it, but it's a very generic. And that's been our standard for all of our blocks. It's in the ACEP guidelines. We did not step into the specific block space based on CPT codes. One question, how much more will I get once I start moving into actually doing this based on the actual block? And two, go ahead.
Oh, no, you mean in terms of if what you're capturing is based on just a simple peripheral nerve?
Yes, that's right.
So
you're missing out on revenue.
You're missing out.
You're missing it out. Get brave. Be brave.
Okay.
Dip into that space.
It was more, and I'll tell you. I mean, it's a long story, but it's because of the work that it happened at Highland to get stuff done in the IT department and get billing and coding on the same page. But it's something I have to do, so it's fine. Second, is there any worry, like if I do a bedside echo and the patient gets a comprehensive echo in-house? Obviously, a lot of times they don't bill my bedside echo. Is that correct, Beth?
So this is how it works. Your place of service in the emergency department and your specialty, and I assume you are, what is your specialty? Emergency? Yeah, perfect. So your taxonomy is different than the cardiologist. And I assume your indication and what you're doing is a little bit different. So your bedside echo and their formal echo can both be billed and both be reimbursed. It gets tricky when you're doing, let's say, a bedside gallbladder, and then in that same ED visit and the patient's still in the ER, you then do a formal
study.
Comprehensive study. Then those two will cancel each other. Yours will get canceled out most likely. Actually, it's whoever drops their claim first will get it paid. Okay. That's actually the truth.
Perfect. I have one more question. So we see a lot of, if I open my own clinic, let's say I just have my own clinic where I was bringing my own ultrasound equipment and doing blocks, I obviously can't charge facility fee. If it's so just the handheld issue comes into play here. If we have handheld ultrasounds in my department, can we use them if the physicians buy them for facility fee? I'm assuming no.
So the answer is no. However, there are some interesting arguments that are happening with those handheld butterflies. A facility fee has a lot more to do with the cost of actually running a structure, not the device itself necessarily. And then there's also modifiers depending on if you own the equipment and you're interpreting the test, or if you're just interpreting the test and you're using somebody else's equipment. And that's where a lot of the radiology modifiers go into it. I would say at this point, and probably for the next 5 years, there's going to be no change in how that works with the handhelds.
So in a sense, if I buy a handheld today and I do a block at my academic institution, the billing code.
The billing would be professional. You would get the professional aspect of it. You would not get the facility aspect.
Great. That's what I thought. Great.
Yep. So one quick question. If we advise or train internal medicine or family medicine, residents, fellows, and whatever, and they go into their own clinical practice and they buy a butterfly with their CME money or their facility, like their clinic budget, is there a way that they can bill facility fees at that clinic?
it depends on how they register and then what you're doing with that. So I'm going to use the term butterfly just so we're all on the same page. So there are personal butterflies and then there are corporately owned butterflies. And a corporate, so we looked at buying, like the hospital buying a bunch of butterflies and letting them, through all the departments. And it was astronomically expensive because they know that then you're going to now tag it as an institution. You're going to say, this is ours, it's a facility, and then you're going to try to do a combined, like a combined bill. The other thing with a facility bill, just so we're all on the same page, it's not as a la carte as, let's say, professional billing is. So when you go to a hospital and you stay there for heart failure, they drop one bill. And that is for a certain, it says, this is for heart failure, whether you have an MCC or not, it goes up or down. Then there's different procedures that are add-ons, like the echo you bill separately and a couple other items, but it's a lot more bundled than professional billing. And that's a whole different can of worms, which none of you really want to know about, trust me.
So painful. I've spent time, I've gotten into this hole and then I've just ran away quickly because it's so confusing.
Yep. I would say, though, from a financial viability standpoint, very quickly, if you start doing a bunch of these ultrasounds and you do a bunch of bedside procedures, very quickly you can show the ROI to buy equipment. I know that we did it by getting a really new fancy ultrasound, and I think it was like $75,000. And we could show, based on our the docs having to do peripheral IVs in the ER. That's how I played with the numbers for the submission for it. So it's not astronomical to just do it on the professional side. I wouldn't touch the facility aspect of it. It gets very complicated very quickly.
Makes sense. We've got a couple of questions in the chat. So Suman Gupta was asking, is there a problem also with storage of the image on a personal device?
Yes.
I guess that would be, that would depend on if you bought it with your LLC funds, if you're hanging a shingle, versus if you bought it with your CME money. I think
it actually is a little bit more complicated than that. So let's say with my CME money, or even as an LLC, I buy my butterfly, but it's the hospital's patient. So when it comes to some HIPAA protected information, there's a lot of HIPAA rules. So I have my certification in compliance as well. The laws with HIPAA and storage of images becomes very complex, especially it has to be on certain partitioned and it needs to be fragmented out. And there's a lot of safeguards that are put in to it. And so your personal butterfly is not at the level for it to be considered to be safe, because what are you doing with those images? And then are you commingling the hospital patient's images with some other stuff, your friend from down the street?
Do some EMRs have a way of actually interfacing the images obtained from Butterfly or not, or is that not a thing yet?
So yes, for a corporate butterfly, absolutely. For a personal butterfly, I don't want your personal butterfly anywhere near my PAC system. Keep your butterfly to yourself.
Yeah, Rachel Liu's done great work with Butterfly and their enterprise software to integrate with their PAC system, so she would be a good resource for that question. We have another question about the 2023 E&M coding changes. Have any of your departments started to use POCUS in the independent interpretation of exams portion of the MDM as opposed to a separate CPT code? If so, have your coders been able to track them? And I would add a third question of, is the reimbursement better? I guess.
Oh, no. You want that as a separate procedure. Bills out better. So for the E&M update, you get certain points for certain things. So an independent evaluation. So I independently looked at the chest x-ray. It's only worth a point of your NDM to help level your chart versus a separate POCUS exam. Doing that and then dropping the CPT code, you're going to make more money on the CPT code as dropping. I would continue to do it as a separate note. You can use that then for your medical decision making, but I would just keep it separate. That way you get more money.
I know that the billing and coding section of ASAP had a very heated debate about that particular question. So if there is any clear data to support CPT coding over upcoding of the visit, that would be really great to know.
Absolutely. I think that as we look at the aggregation of data, and you look at most people, most ER visits, you're going to hit a level 4 easily, most ER visits. And so if you already have enough points sitting there, why burn a point over there when you could just drop it as a CPT code? So I think it depends. I know the group that Kat and I are part of, we have a ton of 4s, and it's easy to obtain, especially with good documentation.
Hey, this is Trent. I asked that question. Thank you for the answer. I work at Hartford Hospital, and our billers haven't been able to get us any concrete info on that. Our reimbursement rate for point of care ultrasound is pretty poor here. It's actually around 4 to 5%, which is actually really, really bad. So we've been told by our financial people to do the opposite of what you suggested, to essentially bill it into the E&M because we get reimbursed for that more. Why that's an issue is something that I still have to figure out and work on. But I'm just wondering if you guys have any numbers to back that up, because I tried to get the numbers from my coders and I essentially got nothing. So if any of you guys have numbers, I would love to take it back to my own coding department, because I cannot figure out how much we're making when it goes into that E&M, because it's not trackable for me.
I think part of it is hard because, when you sit there and you do the E&M, you sit there and you tick off, different points to get a level 4. So you'd have to go into, let's say, every level 4 to then look to see, oh, is this what made it a level 4? So I think it would be kind of hard. Your reimbursement rate is low for your point of care ultrasounds, which is interesting. It would be fascinating to know if somebody from your revenue cycle department has sat down to really see and work the claim to see what the problem is. I know that's something that we sat down and I think we did probably about 4 or 5 years ago. I think this is a pre-COVID activity. And with our revenue cycle company, we started to work those items to figure out why our denial rate was such, and it went up. Or our denial rate went down and our reimbursement went up for that.
Thank you.
Thank you so much, Kat. This has been amazing, eye-opening,
Thank you.
and as usual, scary.
And thank you, Beth, for joining us. And
Yeah.
I hope baby Ava learned something about coding.
Oh, absolutely. Absolutely. Kat has my information. If anyone has questions, she can definitely pass along my email address. These are things that I love talking to physicians about. That way we can advocate for ourselves. And then that way we can also create new service lines and things like that will help the patients and then support new academic endeavors. So feel free to pass my email along. I love answering questions like this.
One more question that just came up in the chat. Should we include the CPT code in our documentation, a proposed CPT code?
So 50-50 on this. I actually hate when doctors do this because a lot of times doctors will put in what they think the CPT code is. And this is mostly a surgeon thing. This is not our ER doctors. And they put in the CPT code and I'm like, yeah, no, you didn't meet that level. And then they will say, well, I put in the CPT numbers. I said, well, the numbers don't mean anything. It's the body of what you wrote. And if you don't meet the level, you don't meet the level. So 50-50, I personally don't do it. I don't want my chart to read like a bill at a restaurant. So I like it to be kind of separate. So I personally don't do that, but that's a personal choice.
Awesome. Thank you very much. I'm going to stop.